Hans, you brought up metastasis-directed therapy and SBRT. How do you integrate that right now into your practice?
For good risk or in general terms?
In general, yeah.
So, Rakibul Hanan, our institution, has done a lot of work with oligoprogressive disease, as others have done at MD Anderson, Dr. Tan, for example. And I think that's a really important concept, right? Because the truth is, if you give immunotherapy, the enemy that we face is typically heterogeneity of the disease. You may have responding 80, 90% of the lesions, but some of them break out. And I do think there's a real opportunity to go after them actually with curative intent, surgically, SBRT, which is a surgical equivalent, but an outpatient regimen, very well tolerated, very effective, very good disease control rate. And so, if not cure, you can potentially buy them a long treatment-free interval, even if they progress in select lesions, before you need to start on a systemic therapy that has significant impact on quality of life. So I use it avidly. I also use it for if patients are on a TKI progressing in just one lesion, but the rest of the disease is well controlled, I may use it. Or patients on HIF2 inhibitors now, right? A uniquely well tolerated class of drug. 1 or 2 lesions are progressing, I may choose to consolidate. So I work, hand in glove with my radiation oncology colleagues.
Yeah, no, it's good to hear that. I think there's multiple opportunities from oligometastatic to they had a response and now you're consolidating to oligoprogressive. So there's multiple opportunities to integrate.
Yeah, and oligometastatic in terms of like they're untreated, but they may just 1 or 2 lesions after several years of being free of metastatic disease after nephrectomy. If somebody's 80 years old, just 1 or 2 lung nodules, I may do nothing else than just stereotactic radiation and hold off on systemic therapy for as long as I can.
Yeah. So one of the caveat, Rana, if I may add to what Hans just mentioned, I think most clinical trials stipulate if a patient is on therapy and they have disease progression, you have to take them off protocol. They don't allow to continue that treatment that the patient may have responded in most sites except for just 1 or 2 sites. So now with incorporating metastasis-directed therapy such as SBRT or SABR as they call it at UT Southwestern, we call it SBRT, you can continue the same systemic therapy. Let's say we're treating a patient with nivo-ipi and the disease melted away, but there is one area that has increased in size. So I think you can direct SBRT to that particular site that has increased a little bit in growth. Yeah. Or if a patient had complete resolution of their metastatic sites, but they present with primary in situ, renal tumor in the kidney, that's the time, it's opportune time to say, okay, they may have progressive disease in the primary because the primary and metastasis are 2 different. The disease is heterogeneous, as Hans said. So the metastasis may have responded beautifully to the immune checkpoint therapy, but the primary is growing a little bit. And I think this is a situation where we send the patient, we refer our patient to the urologist, our colleagues in the urology department, then they remove that kidney. And then many of these patients continue they remain without recurrence, without disease. So we have integrated, radiation to the metastatic sites, and we incorporate surgery because there's still a role for surgery in patients with metastatic RCC. And I'm sure, just to, bring up your trial, I believe you have a trial with your colleagues in radiation to treat the primary tumor with radiation as an option, as an alternative to nephrectomy. Yeah. So I think, that would be, also an option.
Yeah, it's informative. I think it's important for us to do the studies and learn. I think there's a huge need for that, as we saw and heard from our community partners voicing a need for more prospective data guiding the utilization of SBRT. A lot of discussion about variant histologies today and non-clear cell tumors, sarcomatoid tumors. In your current practice, how do you integrate histology in decision-making around IO-IO or IO-TKI?
Yeah.
Katy, do you want to?
Yeah, I think I'll take the easiest one, which is that you gave a great talk today talking about if the best kind of biomarker we have right now for IO is the the use of sarcomatoid features. So certainly if I have a patient that comes into me and their path has sarcomatoid feature, then I'm trying to start IO. And then, really beyond that, I think it was a really nice discussion today about the challenge of small studies, grouping various different disease biologies. And I don't know what the right answer is. I would love us to get to a point where we can be molecularly defining each of these, and whether it's AI or, using different features that would match, to a targeted drug. But I think the challenge the field has had is that they are such different biologies. I mean, just to think at, NF2 driving a cancer versus a, MET-driven cancer. So I think, I hope that we will find a way to both lump, develop these trials that we're seeing in papillary. I think, kudos to our industry colleagues who are doing finally some randomized, trials. So I'm excited to see those. And I think the highest level of data right now I have in papillary is the TKI-IO regimen. So I do tend to, in a papillary situation, especially if they have a high burden of disease, to go with that regimen.
Yeah. How about you all for non-clear cell variant histologies?
Yeah, I mean, chromophobe, for example, is a hugely challenging cancer, right? Normally, immunotherapy doesn't work. I have one patient I cured with immunotherapy with chromophobe, but he had sarcomatoid differentiation. So in my book, when I see it in any histology, I may consider immunotherapy. But yeah, it's a challenge. I do think we are lucky to some degree that when we borrow clear cell targeted therapies and transfer them over to non-clear cell biology, that we actually can see reasonable response rates. I would say if you look at Carbonivo, Lenpembro, 50% response rate, right? Except chromophobe. So I do think it's quite encouraging. It's, as you said, it's not necessarily intelligently done. We just take what we have and apply, but 50% is actually reasonable. We are now getting some follow-up. I think, for example, some more extended follow-up was on lenvatinib pembrolizumab, and I think at the poster it showed actually a duration of response of almost 20 months. So I think that's a good first step, but we need to become more intelligent.
No, that's great. So did you have something to add, Dr.
Well,
Tannir?
I just want to say that it's time to start thinking about these, we discussed and agreed to refer to these as variant histologies rather than non-clear cell. We don't want to define them as what they're not, but define them as what they are and say that this is chromophobe, this is papillary, and papillary, as we heard from today, may not be the best name for this disease because it's also a heterogeneous and there are different disease types. So I think it behooves us to start designing trials with industry. And I loved your comment, Rana, on stage today in your discussion, your presentation about these variant histologies, to say, yes, we can do it. We can design and launch trials for chromophobe, for papillary, without having these basket trials, which we've done for over, a decade, So it's important to design trials that are biology grounded, so really harnessing or leveraging the biology of each of these tumors and identifying targets, as you alluded to and bring that match that we may not have a trial that has already an agent or a therapy that matches this particular molecular profile of this tumor, but we have to make that effort. And yes, as you mentioned, with the partnership with industry and patient advocacy, we can spread the word and we can then ask community oncologists. We need to partner with them, as you mentioned, to refer patients with these rare histologies where there is an unmet need and there is really no consensus how we treat them, and refer them to enroll on these clinical trials. And I would say that, for example, with RMC, as Katy knows very well, we worked with her colleague, Dr. Kimran Rathmal. We were able to design and launch trials for RMC, renal medullary carcinoma, which is a very rare tumor. But once you have a trial, it appears that it's no longer as rare as we think. And, patients are coming from all over to enroll on the trial. And we were able to, we launched a trial 9 years ago for RMC with an EZH2 inhibitor, and we were able to enroll 15 patients in less than a year. And so this can happen when, as they say, build it and they'll come.